Hi, this is Alan Gardner, Senior Lecturer in Advanced Clinical Practice at the University of Central Lancashire, back again with part 2 of this two-part series on the cardiovascular assessment. This time we're focusing on the physical examination. Our learning outcomes for this video then are to apply our knowledge of some relevant anatomy and physiology to the assessment of the cardiovascular system. We're going to be developing our understanding of the physical exam with regard to the cardiovascular system. So hopefully by the end of this video, you'll feel confident to go into class and start learning the process of the physical exam. And then after that, you'll be able to start applying that to some patients. It's really important that we have a systematic approach to all our physical examinations, and that's going to be the case here. So typically, our approach to the cardiovascular exam is that we inspect, palpate, and then auscultate. So by inspection, we mean observing, so actually looking at the patient. We're also using all our senses. We're not just using our eyes, we're going to use our nose for sense of smell. So for example, when we get to the hands, where we're not just looking for nicotine or tobacco staining, we're going to be smelling our patient, and it's a similar example with regard to the GI exam, that we use our sense of smell to observe for fetor on the breath, or for that smell of pear drops that we get in patients with diabetic ketoacidosis. So we try and tap into all of our senses as part of inspection, not just looking. Palpation means to feel, so we're feeling the structures beneath the skin by following our surface anatomy, our surface landmarks, to palpate what's underneath. And then we auscultate, which means to listen with our stethoscope. Once we follow this approach, as I say, this is the typical approach. The way that I remember it and do this clinically actually is to start, so I'll draw on here, so start with the hands, and then I work up the wrists. So from the hands, then we get to the radial pulses, sometimes palpating the brachial pulse, and then the carotid pulse. Then we get to observing and inspecting the face, and back down onto the neck. We can then go onto the chest, carry on down through the chest and to the lower limbs. That includes both sides of the patient, so I'll just try in this direction as well. So I find that this is a really useful way of remembering this physical examination. And it means that we have a systematic approach, which is a little different to the inspection, palpation, auscultation approach. But it means that you're not jumping backwards and forwards. So actually the way that I will go through it in this presentation is to follow inspection, palpation, auscultation. But what you'll see is, for example, we inspect the hands, then we inspect the face and the chest, then we go back to the wrist to palpate the pulses at the radial pulse, and then we palpate at the neck, then we'll palpate the chest. So it's all going a bit sort of backwards and forwards, whereas actually if we just follow the line that I've just drawn onto this patient here, then I think that's a more logical sequence. That's something for you guys to think about when it comes to actually practicing this exam. As with all our physical examinations, it's a really good idea to start by learning on healthy anatomy first. So learning to recognize what's normal, and then starting to recognize abnormalities and pathologies, so then you can work up to actually recognizing and diagnosing them. So we're going to start with inspection, and actually before we even touch the patient in terms of our advanced physical examination skills, we need to make sure that we've got a recent set of physiological observations, so we can perform those first. So we need all the usual blood pressure, pulse, respiratory rate, temperature, pulse oximetry before we start anything. And then our first step with inspection is this general inspection, which is sort of usually referred to as being from the foot of the bed, or just a couple of meters away from the patient, just so that then we can observe them sort of grossly, essentially. So we're looking at the whole patient all at once, and we're trying to avoid zooming in too early. So there might be a temptation to kind of go straight onto the chest or straight to the hands before we actually look at the patient as a whole. And we're trying to make sure that we're safe to continue with the examination, that we're trying to recognize if the patient is clutching their chest in pain, or are they particularly febrile? Are they responding to us as we approach them? Are they showing any signs of pallor or profuse sweating that might preclude us continuing with this full examination? So we're looking for any signs of massive hemorrhage as well. Anything that means that we need to deal with that there and then before we continue with this fairly thorough examination. And actually, just to take a step back before then, I think I mentioned this in a slide at the end of this presentation, but obviously before we start anything, we need to gain consent from the patient. So we've explained everything and made sure that we get informed consent throughout the exam, and that the patient understands that they can ask us to stop at any time. Then we can continue with our general inspection and continue with the rest of the examination. We can start by inspecting the hands, and there's some examples of the sort of things that we're looking for here. And I'm going to start on the right of the screen with finger clubbing. This is a fairly non-specific sign, so we know that this is associated with infective endocarditis, but it's also associated with chronic obstructive pulmonary disease as well. So what we see in these pictures is that we ask the patient to place their fingers together as is demonstrated in the image. And this top left image here, in fact, if I draw a circle around here as I'm talking about, so this top left image here is a normal looking nail bed. So you'll see that this black arrow just points towards what we refer to as Shamroth's window, this sort of diamond shape that if you hold your own fingers together like that, you should be able to see that hole through between the nail beds there. Whereas in finger clubbing, if I just change my color, what we can see in the top right is this loss of angle in the nail bed that develops over a long period of time. And with regards to the cardiovascular system, that might be associated with infective endocarditis. If we then go over to the left of the screen, another sign of infective endocarditis are these splinter hemorrhages here. So I'll just draw a line around some of these, although there is that red arrow pointing toward them. Now these are small, like tiny, what they call microemboli that are thrown off because of the infective processes within the heart in infective endocarditis. They find their way to the end arterioles in the fingers and then show up as these splinter hemorrhages here. We can also see in the middle this picture of fairly marked nicotine staining. Now, why would we look for nicotine staining? Well, if you remember, the purpose of our physical examination is to look for objective signs that confirm or refute the information within our patient's history. So we know full well that patients don't always tell the truth. They might not always admit to just how much they smoke. And so what we're looking for is these objective signs. So this is the patient who tells us that they smoke 5 cigarettes a day, but when we examine them, we might smell a really distinct odor of tobacco smoke. They might have staining, such as what we see in the image here, which tends to contradict this idea of them only smoking 5 a day. And actually, on further questioning, sometimes we find that the patient says, well, I've managed to cut down to 5 a day the week before, but before then they were on 40 a day for several years, and that would be more consistent with the quite marked nicotine staining that we're seeing in the hands there. There's other signs that we can look for within the hands that will show up on some of your other physical examinations as well, but these are 3 of the main ones that I'll mention today. Once we've inspected the hands, we can go up to the face to inspect there, and starting in the top left, what we're seeing here is corneal arcus. So I'll just draw this line around there. We have corneal arcus. Now this, now corneal arcus, and then we have xanthelasma, which is in the patient, the photograph next to it. And these are both signs of hyperlipidemia. So this middle picture in green, the xanthelasma, we get these plaquey deposits around the eyelids as a result of chronic hyperlipidemia. Just as in corneal arcus, we're left with this ring of of light coloured tissue around the cornea as a result of chronic hyperlipidemia. Moving to the top right, we can ask the patient to pull their eyelids down, and we're looking at the mucosa for signs of anemia. Now, actually, in this image, what we're seeing, the one labeled D, we have this sort of well demarcated line, this red line of healthy looking pink mucosa. And if you were to examine someone who's healthy and doesn't have any signs of anemia, then we would see this well demarcated line. And as we go through D, C, B, and A, it's becoming progressively, the patient's becoming progressively more anemic until we get to A, which is this very sort of diffuse looking mucosa that doesn't have a well sort of defined line of pink perfused tissue there. So this is conjunctival pallor as a result of anemia. Then the bottom left here is angular stomatitis. So this is where we get these red sore patches at the edge of the lips there, which again is commonly seen in patients who are anemic. There's also some other signs here that I haven't provided photographs for, but we might observe within the mouth for glossitis, which is inflammation of the tongue. Again, that can be associated with anemia. We might see central cyanosis, and I couldn't find some decent pictures of each of these signs. Central cyanosis, all the photographs I could find just looked unrealistic, and I think that this is one of the issues with learning signs from textbooks and images, that they tend to be depicting the very extreme end of the signs. So the pictures I could find in central cyanosis were almost cartoonish in the level of blue that we could see. We might also see some pallor or diaphoresis, so people looking very pale and sweaty in their face as a result of cardiac pathologies. As we continue our inspection onto the chest, or the precordium, which is the area of the chest around the heart, we're going to observe for any thoracic deformity such as pigeon chest or concave chest, or even some scoliosis. And these deformations might affect the way that the heart's able to function within the limits of the thorax. We also want to observe for any scarring, so we can ask the patient to lift their left and right arms up separately so that we can inspect each side of the chest for any previous scarring from lateral thoracotomy. We want to observe for any signs of pacemaker or other signs of surgery, such as a surgical thoracotomy scar. While we're observing, we need to specifically inspect for any bruising or other swelling that might be evident as a result of traumatic injury. As we move from our inspection to palpation, we should palpate the radial and carotid pulses. We start by palpating the radial pulse, and we can comment on the rate and rhythm as we palpate the radial pulse. And then we really should palpate both right and left at the same time, so we can compare pulses, and in particular palpating for radio-radial delay. Now this is when we might be able to palpate the asynchronicity of the radial pulses. So we would expect to be able to palpate both the left and right radial pulses occurring simultaneously. Now if they split, so we feel the left one first and then the right one shortly afterwards, that this can be as a result of narrowing of the aorta, which is most commonly associated with what's called coarctation of the aorta. Now this is a congenital malformation of the aorta. Because this is a congenital malformation, it's often identified in children, but it can also remain unidentified until adulthood. And quite often, the reason that it's then identifiable is because of some other cardiovascular issue that then accentuates the narrowing of the aorta. For example, hypertension or ischemic heart disease. We should then palpate both carotid pulses. Now we do these separately so that we don't overstimulate the baroreceptors within the carotid arteries. If we palpate both at the same time, then we can stimulate those baroreceptors and cause our patients to to drop the blood pressure, leading them to lose consciousness temporarily. But the best place to palpate the carotid pulse is just beneath the, so we have the angle of mandible here, you can see me drawing that on there, and where it says carotid pulsation here, I would aim for just beneath the angle of mandible, which is actually, this is where our common carotid bifurcates. So we have the common carotid traveling up here and around just below the angle of mandible is where it bifurcates, and it becomes the internal and external carotid arteries. So that's the best place to palpate. It's also the best place to auscultate it when we use our stethoscopes later on in the examination. So to continue our palpation, we're going to move on to palpating pedal pulses. And it's common to palpate two pedal pulses. We can start with our dorsalis pedis pulse, which is nicely identified on this image here. So we have our first metatarsal here, and just lateral to it, we're able to palpate our dorsalis pedis pulse. And this is this branches from the anterior tibial artery, which is one of the main branches from the popliteal artery, which in turn branches from the common femoral higher up the leg. And we're also going to palpate the posterior tibia, which is just behind the medial malleolus. You can see actually drawn on here just very faintly is the medial malleolus there. And if I just change colour, we are palpating just behind that, just posterior to it, is the posterior tibialis pulse. Now, if they're not present, that might be indicative of peripheral vascular disease, so we need to assess for those. And I'm not going to discuss that too much because that's kind of outside the remit of this this brief presentation. As we then continue up the leg, if these pulses aren't absent, we can palpate for the popliteal and femoral pulses higher up the leg. We need to palpate the chest, the precordium. As I said, this is the area over the heart, our surface anatomy over the heart. So there's actually, while we're talking about surface anatomy, there's some important surface anatomy here. Now, I'm not talking about heart sounds within this this presentation. I have a separate lecture on heart sounds, and I go into some depth on that. But within that, I talk about the key landmarks. So we have our 4 areas of auscultation for our our heart sounds. We have our second intercostal space on the right sternal edge here. We have our second intercostal space on the left sternal edge here. Not marked on this is our tricuspid area, which is around the 5th intercostal space, left sternal edge, so around here. But for palpating our apex beat, which is part of our palpation for precordium, we're going to aim for our left midclavicular line. So we draw an imaginary line from our clavicle down the chest here. So this is our left midclavicular line, and it's around the 5th intercostal space. Different textbooks might say 6th or even 4th. I usually go for somewhere in the middle with the 5th intercostal space. And the point of this being that we can draw our heart roughly in here. So we have our apex of the heart supposed to line up with our 5th intercostal space left midclavicular line. So as we palpate the chest, we're feeling around for what we call the point of maximal impulse, when we can actually palpate the apex of the beat of the heart. And this can become displaced in left-sided ventricular hypertrophy, so patients who've had systemic hypertension for a long period of time, or people with heart failure, that this can be displaced downwards, so to the next intercostal space and beyond, and it can also be displaced laterally. So as we locate the apex beat, we can feel in the chest for where it's most prominent, and then we decide, well, is it where it's supposed to be? So it should be in this left midclavicular line around the fifth intercostal space, and if it's displaced laterally or inferiorly, then that can be indicative of some left ventricular hypertrophy. As part of our palpation of the precordium, we also want to just have a generally good feel around, so palpating for any tenderness. If we're able to reproduce the patient's pain through tenderness, then that's a good indication that it might be a musculoskeletal pain, so it could be because of trauma or because of costochondritis, which then starts to shape our hypotheses that we think, well, there's potential that this pain is of a musculoskeletal origin and not of a cardiac cause. So we can palpate around the whole rib cage, and particularly that area over the heart for any tenderness. Now we move on to auscultation. As I said before, I'm not talking about heart sounds in this presentation. I do have a whole other session that goes into some depth for understanding those. If you want to understand those, you can access that. But we do want to auscultate our lung bases. Patients with heart failure are likely to have some signs, in particular crepitus, in the lung bases. Now we need to do this posteriorly. The purpose of these images is to demonstrate that we have our three lobes in the right lung. So we have our right upper lobe, our right middle lobe, and our right lower lobe. And what we're seeing is that we're unable to auscultate the right lower lobe anteriorly. This wraps around to the back and is accessible posteriorly. So we need to auscultate our lung bases posteriorly. And it's the same with our left lung as well. I mean, there's only two lobes here, the left upper lobe and left lower lobe. And again, that's going to be accessible posteriorly. So we auscultate for any potential crepitations in the left and right lower lobes. We also want to auscultate our carotid arteries. Now we're specifically auscultating for bruits. Now bruits are a whooshing sound heard on auscultation. If the patient has healthy, unoccluded arteries, then we won't be able to auscultate anything. But if a patient has atherosclerosis of the carotid arteries, then we're likely to be able to hear a bruit. We're aiming the bell of our stethoscope at the same place where we palpated earlier, so we can see there's this bifurcation that's demonstrated really well on this diagram. So as I draw my let me choose green, draw my green arrow up here, we can then get to this point, which is where the common carotid bifurcates into the internal carotid and the external carotid. We know that atherosclerosis collects predominantly around bifurcations. So we find our angle of mandible, and we are just inferior to that, and this is where we're going to place our stethoscope. I mentioned at the beginning of this presentation that we need to make sure that we gain consent at the beginning and that we thank our patient at the end of the examination. We should make sure that our communication skills are maintained to a really high standard throughout, and that we communicate any findings to our patient as well. Now, you may want to do this just by communicating any findings at the end, or you might want to talk to your patient throughout. I think that that's going to depend on the nature of the relationship that you form with your patient and how confident and competent you feel with the exam at the time. Exposure is a really important part of all physical examinations, and in particular asking our patients to take their shirts off. And if we have to go as far as palpating femoral pulse, for example, then it's going to mean exposing other parts of the patient's body as well. So we need to make sure that we uphold their privacy and dignity throughout the examination. And like I said at the beginning of the video, that our patients need to know that at any time they can ask us to stop if they become uncomfortable. And it's a really good idea to just explain the whole process as you're going along, just so that everything feels open and natural as much as possible, and that you're able to put your patient at ease throughout the examination. That gets us to the end of this video. As you can see, there's just one reference here, and that's because at the University of Central Lancashire, we base our physical examinations on the Bates Guide to Physical Examination History Taking. We have done for several years now. The reason being that obviously there's other examination textbooks available. However, we find that our students find it much easier to just access a single one. There would be potential for using different textbooks for example, the cardiovascular system, and a different one for the neurological system. Then that just becomes quite confusing. So all of this whole examination process has been based on the Bates Guide. You will find that there's subtle differences between Bates and then, for example, McLeod's. And obviously there's some textbooks that are specific to a certain system, whereas Bates covers a really broad set of physical examinations or a broad set of systems. So it's really accessible, and that's the reason that we only use this one. So then no matter which system you're examining or that you're revising for your assessments, you can just go straight to the Bates Guide and know that that's what we've based our exam process on. So hopefully by the end of these two short videos, you feel as though you've had a good exposure to the history taking and physical examination process for assessing the cardiovascular system. Thank you very much for listening, and best of luck with the rest of your learning.